Usually when we think about the digestive system, we picture it as, well, just a passive plumbing system.
Right, like a simple pipe.
Exactly, just a fleshy tube that basically simply moves things along from point A to point B. But today, we're taking a deep dive into a clinical compendium that, honestly, it completely shatters that image.
Yeah, it really does. It's a totally different way to look at our anatomy.
Yeah, so we're looking at the small bowel today, and I want you, the listener, to completely throw out that idea of a simple pipe. Instead, I want you to picture this 20-foot, high-stakes, bustling transit system.
Which is much more accurate, yeah.
Right, because we're talking about an organ that deploys its own dedicated immune defenses. It grows incredibly bizarre functional tumors, and it's home to these silent, ticking time bomb emergencies.
And while the sources we're unpacking today are intensely detailed, I mean, they are essentially clinical Bibles built for gastroenterologists and abdominal surgeons, the underlying physiology here is fascinating.
Oh, absolutely.
It reveals some absolutely incredible stories about human survival. It shows us just how tightly regulated our internal systems have to be.
And how quickly things can spiral completely out of control when those systems fail, right?
Exactly.
So we're going to navigate this clinical maze together. We'll explore how diseases disguise themselves, what happens when cellular mutinies take over, and how the body desperately tries to adapt when it literally runs out of runway.
There's a lot of ground to cover.
There is. Okay, let's unpack this. The compendium spends a lot of time on the immune system of the bowel, right? Specifically focusing on a staging ground called the ileocecal region. What exactly are we looking at there?
So the ileocecal region is the exact anatomical border where the small intestine ends and the large intestine, or the colon, begins.
Okay, so a major checkpoint.
A massive checkpoint. And clinically, it's notorious. It is the primary site for a huge case of mistaken identity between two entirely different diseases.
Which are?
Intestinal tuberculosis and Crohn's disease.
Ah.
Both cause extreme inflammation, both cause severe abdominal pain and weight loss, and, well, to the naked eye, they can look nearly identical.
So if you're a doctor looking at a patient's scans, how do you even tell them apart? I mean, the compendium mentioned clinicians using barium swallows to look for very specific physical reactions, like the Stirling sign. How does that work?
Right. So when clinicians run barium through the digestive tract, it coats the lining, so it shows up bright white on an X-ray.
Got it.
They're looking to see how the bowel physically handles that fluid. In intestinal TB, the Stirling sign appears. What you see on the X-ray is a severely narrowed terminal ileum, the very end of the small intestine, but it holds absolutely zero barium.
Wait, really? Zero?
Zero. The barium is visible above it and visible below it in the colon, but the inflamed section itself is just completely empty.
Wait, so the fluid is just flying right through it?
Basically, yes.
If we go back to our transit system analogy, is it sort of like a rapid transit express lane?
Right.
Like the tissue is so irritated and inflamed by the tuberculosis that the bowel just spasms?
Yeah.
Yes, exactly.
And it just completely bypasses that specific station and refuses to let anything stop there.
That is a perfect way to visualize it. The inflammation makes the muscle hyperactive, so it just rapidly routes everything past it.
Wow.
Conversely, right next door, you might see what's called the Fleischner sign.
Okay, what's that?
This is where the actual valve regulating traffic between the small and large bowel is essentially blown open. Its lips are thick and swollen, and it's unable to close.
Oh, yikes. But the compendium stresses that doctors can't rely on imaging alone, right? They have to look at the actual tissue under a microscope.
They do. They really have to look at the granulomas.
Granulomas.
Yeah, these are tiny clusters of immune cells that form when the body tries to wall off an infection or an irritant. And this is the definitive difference between the two diseases.
Okay.
Crohn's disease features non-caseating granulomas. Intestinal TB features caseating granulomas.
Wait, caseating, what does that mean?
Caseating essentially means the center of that immune cluster has turned into a soft, cheese-like, dead tissue.
Oh, gross.
Yeah, it's because the tuberculosis bacteria are actively destroying it from the inside out.
So why is making that specific distinction so incredibly high stakes? Like, what happens if a doctor just assumes it's Crohn's disease and doesn't check?
Well, what's fascinating here is that the treatments are polar opposites, which is why getting it wrong is a complete disaster.
A disaster how?
If a doctor misdiagnoses the intestinal PB as Crohn's disease, they'll prescribe standard Crohn's medication. Those are anti-TNF drugs, which are powerful immunosuppressants.
Right.
They work by blocking a chemical called tumor necrosis factor, which shuts down the inflammation.
But wait, isn't that chemical what the body is using to build that wall around the tuberculosis?
Exactly. You are systematically dismantling the physical wall holding the tuberculosis in check.
Oh, no.
By turning off the body's security system, you disastrously unleash a latent, highly destructive TB infection to just flood the rest of the body.
Wow, that's a terrifying margin of error. It really is. That's why TB must be rigorously excluded first with specialized tests before you ever give a Crohn's patient immunosuppressants.
That makes total sense.
Yeah.
And speaking of rogue elements inside this transit system, let's transition from infectious mimics to cellular mutinies, tumors. Now, I noticed in the data that the small bowel actually rarely gets cancer, despite being so huge. Why is that?
It is surprisingly rare. It accounts for less than 5% of all gastrointestinal cancers.
Which seems crazy.
It does, but it's highly protected by a few brilliant mechanisms. First, the rapid transit time we just talked about means potential carcinogens don't sit in one place for very long.
Right, they get flushed out.
Exactly. Second, the environment is highly alkaline, and the small bowel produces massive amounts of an antibody called IgA to neutralize threats. It's essentially a self-cleaning oven.
A self-cleaning oven, I love that. But here's where it gets really interesting, because when a tumor does manage to take hold in that environment, particularly in the middle section of the gut, it's not a standard silent lump of cells.
No, it's not.
The compendium calls them neuroendocrine tumors, or NETs.
Right. And what makes NETs so unique is that they are actively functional. They are essentially rogue factories.
Rogue factories producing what?
Midgut NETs secrete massive, massive amounts of a hormone we normally associate with the brain, serotonin.
But wait, if my gut is suddenly pumping out massive amounts of serotonin into my bloodstream, shouldn't I feel the systemic effects of that immediately?
You would think so, but most patients don't feel it for years.
Why not?
The reason comes down to the anatomical plumbing. The blood leaving your intestines doesn't go straight to your heart. It gets routed directly to the liver first.
Okay.
The healthy liver acts as a massive chemical filter. It contains enzymes that eagerly break down all that excess serotonin before it can ever reach the rest of your body.
Oh, I see. So the liver is essentially acting like a giant bouncer at an exclusive club.
A bouncer,
Right.
yet.
Like the tumor is down in the bowel throwing this wild, chaotic, hormone-pumping party, but the bouncer, the liver, catches all the noise at the door and filters it out. So the rest of the body, out on the street, has absolutely no idea the party's even happening.
That is exactly what happens. The liver quietly manages the chaos. Because of that, a patient only develops carcinoid syndrome, which is the severe whole-body reaction to the serotonin, if the tumor manages to bypass the bouncer.
And how does it bypass the bouncer?
By metastasizing. The tumor spreads directly into the liver tissue itself. Because the new tumor cells are now sitting past the filtration mechanism, they just dump serotonin straight into the systemic circulation.
Man. And the symptoms of this systemic dump are intense, right? How do clinicians remember all the ways this affects the body?
They use the mnemonic BFDR.
BFDR. Okay.
It stands for bronchospasm, where the airways tightly constrict, making it hard to breathe. Flushing, where the blood vessels in the skin widely dilate, turning the patient bright red.
Wow.
Severe diarrhea from the hyperactive bowel. And the R stands for right heart issues, specifically a condition called TIPS, that's tricuspid insufficiency and pulmonary stenosis.
Wait, the hormones actually physically damage the valves of the heart?
Yes. The constant bombardment of serotonin triggers fibrotic tissue, kind of like stiff scar tissue, to build up directly on the heart valves.
That's horrifying.
It is. Interestingly, though, it only damages the right side of the heart. By the time the blood pumps through the lungs to get to the left side of the heart, the lungs have actually filtered out the serotonin.
Wow, the body's filtration checkpoints are amazing. But the compendium mentions that the chronic symptoms aren't even the scariest part.
No.
The absolute highest stakes scenario is something called a carcinoid crisis. What triggers that?
A carcinoid crisis is an acute life or death emergency that usually happens on the operating table.
Like during surgery?
Yes. If a patient with one of these tumors goes into surgery, say, to have the tumor removed, the physical manipulation of the tumor by the surgeon's hands, or even just the chemical trigger of administering anesthesia, can cause the tumor to panic.
Panic and do what?
And dump a lethal, overwhelming amount of hormones into the blood all at once. The patient's blood pressure wildly swings, their airways completely close off. It's disastrous.
So how do you even operate on them if just touching the tumor causes that?
You have to lock the tumor down before you even start. The surgical team must administer precisely 500 micrograms of an intravenous drug called octreotide before inducing anesthesia.
Octreotide.
Right. It physically binds to the receptors on the tumor, blocking the release of the hormones.
It's literally like defusing a bomb just seconds before the timer runs out.
That's a very accurate way to put it.
Okay, so let's look at what happens after the surgery. Say a patient has one of these tumors removed, or maybe they've suffered from that severe Crohn's disease we discussed earlier,
Right.
and the surgeons have had to go in and remove a large section of the bowel entirely. The compendium talks about a limit here. If you remove too much of the transit system, you induce short bowel syndrome.
Yes. Short bowel syndrome is clinically defined as having less than 200 centimeters of viable small bowel remaining, or, losing more than 50% of its total original length.
That sounds like a lot to lose.
It is. But what's crucial here isn't just the length. It matters immensely which specific part of the bowel was removed. Losing the terminal end, the ileum, is vastly more detrimental than losing the upper sections.
Why is the ileum so irreplaceable?
Because the ileum performs highly specialized jobs that the rest of the bowel simply cannot learn to do. It is the exclusive site for absorbing vitamin B12, which you need for nerve function,
Right?
and for absorbing bile salts, which you need to digest fats. Even more importantly, the ileum secretes hormones that act as the ileal brake.
The ileal brake. Okay, let me think. You know how normally after you eat a big heavy meal, you feel full and satisfied for hours and your stomach empties really slowly?
Yeah.
Is that the brake working?
Exactly. The ileum senses the unabsorbed fats reaching the end of the line, and it sends a chemical signal back up to the stomach saying, slow down, we are at capacity down here.
Ah, so if you surgically remove the ileum, you literally cut the brake line.
You do. The stomach dumps food into the shortened bowel rapidly, and everything rushes through far too fast to be absorbed.
So what does this all mean for the patient's day-to-day life?
It leads to severe life-altering malabsorption. If they have an extremely short bowel, under 60 centimeters, they often end up entirely dependent on total parenteral nutrition, or TPN.
Which is an IV, right?
Yes, it means feeding them all their daily nutrients intravenously. But if they do have some bowel left, and crucially, an intact colon, they face a very strange set of complications.
Yeah, the compendium mentioned something called D-lactic acidosis, which just sounded wild to me.
It is wild. Because the small bowel runway is too short, huge amounts of unabsorbed carbohydrates crash directly into the colon. The colon was never designed to handle that.
But the bacteria are happy.
Oh, the millions of bacteria living in the colon, they are absolutely thrilled.
Right. I was thinking about this, and it sounded exactly like a rogue fermentation party.
A rogue fermentation party, I like that.
Yeah, you have all these bacteria suddenly getting an all-you-can-eat buffet of raw carbs,
Yeah.
so they just feast on it. And as a byproduct, they ferment it into this massive wave of D-lactate acid.
Right.
And that acid gets absorbed into the patient's bloodstream, right? Making them neurologically toxic, acting almost like they're heavily intoxicated.
That is exactly the mechanism. It
Yeah.
is colonic bacterial fermentation running completely out of control. But if we connect this to the bigger picture, what is truly remarkable is the bowel's sheer will to survive.
How so?
Over the course of 1 to 2 years after surgery, the remaining small bowel will physically adapt. The tiny finger-like structures inside the villi will grow significantly deeper and wider to maximize whatever absorptive surface area is left.
And doctors can actually help that process along, right? The compendium mentioned drugs and even more surgery to fix the surgery.
Yes, medicine can amplify this natural adaptation using drugs like teduglutide. It's an analog of a hormone called GLP-2, and it chemically forces the bowel lining to rapidly grow thicker.
Wow.
Or surgeons can perform lengthening procedures like the STEP procedure. That's serial transverse enteroplasty.
What does that entail?
They essentially make zigzag cuts along a widened piece of bowel, stapling it in a way that physically reshapes it from a short, wide pouch into a longer, narrower tube, effectively giving the food more runway.
That's incredible engineering.
Mm.
But what happens when the healing process fails entirely? The sources had a whole section on enterocutaneous fistulas.
This is a major surgical complication. A fistula is an abnormal physical tunnel that forms between the bowel and the outside skin of the abdomen. Digested contents literally leak out of the body.
Oh man, that sounds awful.
It is. The body is supposed to naturally heal and close these tunnels over time, but sometimes it stubbornly refuses. When that happens, clinicians use a specific mnemonic to figure out why the healing has stalled.
Is that the friends list? How does a doctor use that to troubleshoot the failure?
Right, so if it's not closing, the doctor goes down the friends list. Is there a foreign body, like a lost sponge, keeping it open? Is there radiation damage preventing cell growth? Is there an underlying infection or IDD like Crohn's? Has epithelialization occurred, meaning skin cells have permanently lined the tunnel? Is there a neoplasm, a tumor in the way? Is there a distal obstruction further down the pipe, forcing high-pressure contents out the side door? Or is the patient on steroids, which chronically halts the healing process?
Wow, so they just check those off one by one.
Yeah.
And to actually manage it, they use the SNAP protocol, right?
Yes.
Controlling sepsis, managing nutrition because the patient is constantly leaking fluids, mapping the anatomy with scans, and making a plan for a very delayed definitive surgery. It sounds like it requires immense patience. You just have to get the bowel time.
You do, but moving from chronic surgical complications, there is one scenario in the compendium where the bowel has absolutely zero time. The tissue doesn't have months to adapt or heal. We are talking about acute mesenteric ischemia.
The vascular ticking time bomb.
Ex-
The small bowel demands a massive amount of blood flow to do all this heavy lifting we've been talking about, right? So if you suddenly cut off that blood supply, the tissue begins to die rapidly. The mortality rate for this is a staggering 50 to 70%, even in modern hospitals.
It is a massive, catastrophic emergency, and clinically, it presents in a way that is highly deceptive. The compendium notes the hallmark symptom is pain out of proportion to the physical exam.
I kept seeing that phrase. What does pain out of proportion actually look like if you're the doctor standing in the ER?
It means the patient is brought in screaming in absolute uncontrollable agony. But when the doctor gently presses on their abdomen to examine them, the stomach is soft, it's not rigid, it's not distended, there's no obvious mass. The physical exam just doesn't match the level of suffering.
So to the doctor, it's the medical equivalent of a house looking perfectly fine on the outside during a drive-by appraisal, while a massive destructive fire is completely gutting the inside walls.
Exactly. And the fire in this case is rapid tissue necrosis, or death. Finding the source of that blockage immediately is the only way to save the patient's life.
So what causes the blockage?
Well, 50% of the time the cause is embolic. A physical blood clot, usually originating from a fluttering heart in atrial fibrillation, breaks off into the bloodstream. It gets pumped down into the superior mesenteric artery and wedges itself in like a cork, completely starving the entire organ below it.
So that's a physical blockage.
Yeah.
But the data shows 20% of the time it's something called NOMI, right? Non-occlusive mesenteric ischemia. That sounds like a contradiction. How can it be ischemic, meaning starved of blood, if it's not occlusive, meaning there's no blockage?
It happens in what we call low flow states. Let's say a patient is in severe shock or heavily using cocaine or their heart is failing. The body realizes it's losing blood pressure, so it panics.
Okay, what does it do?
It aggressively clamps down the blood vessels in the gut to reroute all remaining blood to the brain and the heart to keep you alive. The vessels in the bowel squeeze so tight for so long that they accidentally starve the bowel tissue to death.
Wow.
Yeah, there is no physical clot to remove. It is purely a profound lack of pressure and flow.
Which means the treatment has to be radically different depending on the cause, right?
Yeah.
If I have a physical clot blocking the pipe, you need surgery. You do an embolectomy to pull the clot out.
Right.
But if it's NOMI, surgery won't help at all because there's literally nothing to pull out.
Precisely. If it's NMI and there are no signs that the bowel has already ruptured, the treatment is chemical. Doctors inject a medication called intra-arterial papaverine directly into the artery.
Papaverine, what does that do?
It's a powerful vasodilator. It forcibly relaxes the muscle of the blood vessel, opening it back up to restore the flow. But regardless of the cause, time is quite literally tissue here. Every minute the bowel is starved of oxygen, more of that vital transit system dies permanently.
It's an unbelievably dramatic, acute crisis. But for our final section, I want to look at the exact opposite.
Okay.
We're looking at insidious, everyday intruders. Things that don't cause a sudden agonizing fire, but instead slowly and quietly destroy the bowel's ability to do its job over the course of years. Let's talk about celiac disease and Whipple's disease.
Let's start with celiac disease. The trigger here is surprisingly common. Everyday gluten and gliadin proteins found in wheat, barley, and rye.
Which are in everything.
Pretty much. In individuals who carry specific genetic markers, namely HLA-DQ2 or DQ8, their immune system recognizes gluten as a dangerous invader. But instead of just attacking the gluten, the immune system becomes confused and launches a full-scale assault on the lining of their own small intestine, specifically targeting the duodenal villi.
And the compendium is very specific about what that autoimmune destruction looks like under a microscope. It lists villus atrophy, crypt hyperplasia, and an invasion of lymphocytes. So to visualize villus atrophy for our listeners, imagine the inside of your bowel is normally lined with this plush, highly absorbent shag carpet. Those thick fibers are the villi, and their job is to soak up all the nutrients passing by.
Good analogy.
Thanks. Celiac disease essentially takes a microscopic razor and aggressively shaves that plush shag carpet down to a smooth, flat hardwood floor.
That is exactly what is happening structurally, and the functional consequence of that is devastating. Suddenly you have absolutely zero surface area to soak up a spill, or in this case, to absorb crucial everyday nutrients like iron, folate, and vitamins.
And what happens if someone with celiac just ignores it and keeps eating gluten?
The consequences of leaving that unchecked are severe. If the immune system is constantly provoked, the chronic simmering inflammation leads to severe iron deficiency anemia, early onset osteoporosis because they can't absorb calcium.
Right.
And most dangerously, the chronic cell turnover dramatically increases the risk of a highly aggressive cancer called EATL, that's enteropathy-associated T-cell lymphoma.
Oh, wow. Cancer.
Yeah. The only treatment is a strictly lifelong 100% gluten-free diet to let that shag carpet grow back.
So celiac is an autoimmune misfire triggered by a harmless protein. But Whipple's disease, which also causes severe malabsorption, is totally different. That's an actual living bacterial invader, right?
Yes. It is caused by a specific bacteria called Tropharema whipple. It physically infiltrates the gut lining.
How do they find it?
When a doctor takes a biopsy, they identify it by looking for something called PAS-positive macrophages. Macrophages are the body's cellular garbage trucks. They arrive and swallow the invading bacteria.
Sounds like they're doing their job.
Well, they try, but with Tropharema whipple, the macrophages can't actually digest them, so they just gorge themselves, swell up, and pack into the intestinal wall, physically blocking the absorption of nutrients.
But the symptoms of Whipple's go way beyond just the gut, don't they? The mnemonic clinicians use is WAND, W-A-N-D, weight loss, arthralgia, which is severe joint pain neurological issues, and diarrhea.
And this raises an important question, doesn't it? We are talking about a localized bacterial infection trapped inside the wall of the small intestine. So why on earth is the patient experiencing severe joint pain and losing their memory or having neurological deficits?
Because the gut isn't an isolated pipe.
Exactly. It serves as a powerful reminder that the gut is deeply physically wired into the rest of the body's systems. As the bacteria multiply, both the bacteria and the inflammatory immune complexes the body creates to fight them escape into the bloodstream.
Oh, so they travel.
Right. They circulate systemically, they settle into the joints, causing the arthralgia, and they actually cross the blood-brain barrier into the central nervous system.
That is terrifying.
Because the infection is so deeply entrenched across these barriers, the treatment is intense. It requires 2 straight weeks of intravenous ceftriaxone to forcefully cross into the brain, followed by a full, uninterrupted year of oral antibiotics to clear it from the gut.
A full year. It just highlights how tenacious these intruders can be. All right, well, we have covered some serious clinical ground today. We certainly have.
We started by looking at how intestinal TB can brilliantly disguise itself as Crohn's disease, creating that Stirling sign express lane, and how blocking the body's immune response can cause a disaster.
Right.
We explored the liver acting as a heroic bouncer for those wild serotonin-secreting carcinoid tumors. We discussed the body running out of runway with short bowel syndrome, the terrifying invisible house fire of mesenteric ischemia, and finally, the slow, microscopic destruction of that shag carpet in celiac disease.
It is truly a remarkable organ. The ultimate takeaway from unpacking all of this dense clinical data is recognizing that the small bowel is an incredibly dynamic, resilient structure.
Yeah.
It isn't just a tube. It is actively managing complex chemical filtration, hormonal regulation, and frontline immune defense every single second of the day.
It really is a high-stakes transit system.
Okay.
But before we wrap up, I know you had a final thought based on how this organ adapts to trauma over time. I do. We discussed short bowel syndrome and how if you surgically remove 50% of a patient's small intestine, the remaining tissue will literally alter its own cellular destiny.
Right.
It will force its villi to grow deeper and wider over the course of years just to compensate for the massive loss of length. It makes you wonder, if a 20-foot organ can miraculously recognize its own deficit and reshape its physical architecture just to keep us alive. What other dormant extreme regenerative capabilities might the human body be hiding that we simply haven't learned how to unlock yet?
Now that is a thought to chew on.
Uh,
Next time you hear your stomach rumble, just remember there is an entire, highly sophisticated transit system down there, working around the clock, battling invaders, and filtering toxins just to keep the peace. Thanks for joining us on this deep dive. We'll see you next time.